Women shape global healthcare. Women are doctors. Women are scientists, researchers. They are healthcare workers and policymakers. Women are managers and patient advocates. Women are family and friends. They are mothers and they are daughters. But women spend 9 years of their lives in poor health, and with that 25% more than men. Many reasons exist for this gap between women's and men's health. Yes, there are maternal or women-specific health issues, but also many diseases that affect women differently than men, or more seriously, or more often. But this gap is also a result of neglect. In a science treating human biology as male, where man is the default, and where women's health goes understudied, under-recognized, underdiagnosed, and undertreated. It doesn't have to be that way. Closing the health gap will improve the lives of women and create positive waves in society that will spill into future generations for everyone. You can even translate it into numbers. According to an international study, closing the health gap would bring 137 million more women into full employment, lift themselves and their families out of poverty, and boost the global economy. Every $1 invested in women's health generates $3 in economic growth. Closing the health gap would cause the world's economy to grow by $1 trillion annually, a 1.7% increase in per capita GDP. It would affect women, men, families, communities, nations, and it would make the world healthier. Will we rise to the challenge?
Good morning, dear guests, and a very warm welcome to this World Health Summit event hosted by Daiichi Sankyo. I am Melinda Crane. I'm a journalist and a political economist and work a good deal in the area of healthcare and medical innovation, and it is a great pleasure to accompany you today as moderator. Our title is Time to Act on Women's Health, and for very good reason. As you saw in the film, we are not doing right by women when it comes to health. The gender gap begins with underdiagnosis of killers like cardiovascular disease and cancer, leading causes of female mortality, and it encompasses inadequate treatment, as well as specific disaggregated data, we don't have enough of that, and focused R&D. The world's women would have an extra healthy 7 days a year, adding up to 500 days over a lifetime, if we change the situation. Health officials, some policy leaders, and also international organizations have pledged to close the gender gap. But how do we turn those commitments into action? You saw the question, will we rise to the challenge? That's what we want to talk about here today. Over the next 90 minutes, following greetings from our host and a keynote by a female public policy health leader and patient advocate, we'll explore not only the causes and impact of this glaring gender gap in a panel with very high-level speakers, but we'll also focus on solutions and approaches that can really make a difference on the ground. And I will take this opportunity to greet all of our panelists very warmly, and I'll introduce them individually a little bit later. Now, it is my pleasure to hand over to our host, the CEO of Daiichi Sankyo. He's had a 46-year career with the company, beginning in research, and following that, he has held leading positions both as COO and as president. Dr. Sunao Manabe-san, it is a great pleasure to hand over the floor. Thank you, sir.
Good morning, ladies and gentlemen, distinguished panelists. I am very honored to open today's session with some introductory words and thoughts. Equitability in health is a topic that is close to my heart. and important to our company, Daiichi Sankyo. Prevention, modern therapies and medicines, and aftercare should be accessible to everyone independently of location, origin, and gender. Here, women's health became a matter in the spotlight of interest for good reason. Women's health goes far beyond the question of access. Women are underrepresented in clinical trials, have longer time to diagnosis, often do not get appropriate medication and doses, and are, in many health systems, not appropriately involved in important decisions on women's health. For example, when it comes to the reimbursement of new medicines. These are just a few facets of this important topic. Of course, women's health must be seen in a broader context of gender equality to build more resilient societies and drive progress toward equality and sustainable development. We must prioritize gender equality. The United Nations has acknowledged gender equality as one of the 17 Sustainable Development Goals, SDGs, and necessary foundation for a peaceful, prosperous, and sustainable world. We have seen much progress over the last decade, but there is still a long way to go. It concerns me to read that the UN proclaims the world is not on track to achieve a gender equality by 2030. It is up to all of us to collaborate towards achieving this goal, and healthcare must play a very important role in our joint effort to address the many unsolved issues of women's health. Let me have the following questions for women's health with you. What exactly is the challenge? What is at stake? Why research and medical progress plays a crucial role? I would like to briefly illustrate answer to those questions with two examples of non-communicable disease, NCDs, cardiovascular disease and cancer. NCDs are still the leading cause of morbidity and mortality among women worldwide, responsible for 2 in 3 deaths. The most common one is cardiovascular disease, representing almost 30% of all global deaths, mostly caused by heart attack and stroke. Although women generally have a lower prevalence of CVD than men, a number of studies have shown that after an acute cardiovascular event, women have a greater death rate and worse prognosis. The same situation applies for cancer. More than 19 million new cases are diagnosed worldwide every year. The WHO predicts that the global cancer burden will further increase by approximately 50% between 2020 and 2030. Sorry, 2040. Speaking of women's health, the most prevalent cancer type is breast cancer, in which 99% of cases affect women. Every year, more than 2 million women worldwide are newly diagnosed with breast cancer. CVD and breast cancer are just two of many examples of how major global health issues and women's health issues are linked. Addressing these issues is a huge and complex task. The complexity and multifactorial linkages between risk factors, diagnosis opinions, and available treatments make it evident. We need joint effort from all sectors of healthcare, including healthcare providers, scientific communities, governments, and private sector to turn improvement measures into action. I would also like to give you an example of how we in Japan have jointly succeeded in achieving significant progress for women's health. 30 years ago, the Japanese government introduced the first comprehensive 10-year strategy for cancer control. This holistic approach in fighting cancer continues until today. In March last year, the Japanese government approved fourth basic plan for promotion of cancer control. The plan is the basis of our country's cancer policy and includes many concrete measures in various health areas, such as enabling better access to screening programs and early detection, systemic collection and analysis of data on cancer incidence, treatment, and outcomes, social support for cancer patients and their families, public education in terms of prevention, and investments in research and therapy. Many of these measures explicitly focus on women's health, and Japanese Ministry of Health, Labor and Welfare is delivering coupons for free screenings for women-specific cancers and promoting women-specific health education. For women's health, ICWH was just opened on October 1st in Tokyo. Another factor that gives me hope that we will be able to sustainably improve women's health is the rapid medical progress in recent years, driven by excellent public and private research from scientists around the world. Scientific expertise is also the core of what we do at Daiichi Sankyo. Since our company was founded in Japan more than 120 years ago, we focus on providing innovative pharmaceuticals for patients and thereby contribute to the enrichment of quality of life around the world. Therefore, we invest almost 1/4 of our annual sales in R&D. The focus of our science are the two leading causes of death among both women and men: cancer and cardiovascular diseases. As a company, we try to reflect gender equality and women's health as an essential element of our culture and employee services. 2 examples. First, we have world-class female scientists working in our laboratories in Tokyo and world. To achieve our mission and vision as a company, we create a working environment that empowers these female scientists in the best possible way in their skills and efforts. In 2016, we emphasized our commitment to this by publicly pledging to actively contribute to the United Nations Women's Empowerment Principles. Second, we focus on women's health beyond our research. In Japan, we run women's health projects such as an annual women's health seminar, a consulting service, and a portal for women's health. To emphasize these ambitions, we included women's health in our strategy as a core area of action for the upcoming years. Let me conclude. The challenge of non-communicable diseases in global women's health is profound and multifaceted. Therefore, we need to mirror this by multifaceted strategies to reduce the impact of NCDs on women. We need specific healthcare policies that address women's health issues, ongoing research and strong commitment for scientific and medical progress. We need to understand global health and women's health cannot be separated. Let's together prioritize women's health in tackling the challenge of NCDs. If we succeed in reducing the burden of disease for women, we can achieve better health outcomes, not only women, but in general for societies around the world. This is important to me and close to my heart. Thank you very much.
Thank you very much, Dr. Manabe-san, for those very important messages and for your commitment to this topic, making our discussion today possible. We hear next from a health policy activist who says it is time to shine a light on women's health challenges that are often treated as if they're invisible. She is a former member of the Swedish Parliament and founder of the advocacy platform Focus Patient. She currently serves as president of the European Patient Safety Foundation. She's had both cancer and heart disease and is thriving. It is a pleasure to hand over the floor to Pernille Gunther.
Thank you so much. It's an honor to be here and a really pleasure to see all of you in this morning to tackle this very important issue. I think, I could tell you a lot of facts and figures, and I will not do that because you can find that out yourselves. Or you will maybe hear more of it later on. I will tell you a story, and it's not a bedtime story, I can assure you. So let's see. I like to tell you about this Sunday afternoon. It was in mid-March. It was horrible weather, and I had a period of coughing since a month back when I had to stay home for 3 days. Can you imagine? Be home for 3 days, that's really a long time. And your emails will just rise in your email box and so on. And I had an influenza, and many people in Sweden had that winter. And this afternoon, I was thinking, if not the best thing would be to be examined by a doctor and get some antibiotics. I mean, maybe it's a pneumonia, not only in one lung, maybe it's even both lungs. That's what I thought. I got an appointment at an emergency care department at the health center, and my husband said he would go with me. Just let me pick up the car from the parking garage and meet me outside, he said. I went out on the street. I mean, the parking garage was just 100 meters away. And suddenly I had some crazy thoughts coming up in my mind. If I fall down here on the pavement, people will see it and will take care of me. Or they know who I am. I mean, my neighbors is all around here. They know who I am if I fall down. I managed to go to the car, but when we entered the door to the health center, I could suddenly not breathe. The healthcare personnel, they told my husband, please get her into the car again and go to the hospital. And we will tell the emergency care unit that you will come. Quite crazy. They brought me into an emergency room, did some tests, and I had to stay overnight, of course. In the morning, my husband came with some toiletries, clothes, and so on. And I mean, it was before he should go to work. And lucky for me, there was a doctor coming in at that moment, and he told us, well, Pernilla, you might have this or that cardiovascular disease, but the most important thing is, I think you need a new heart. Very pedagogic, I would say. In Sweden, we also have a saying that when people really get surprised, they look like birdhouses. You know, birdhouses, as you put it on a tree and so on, when you look like this. And I think that was exactly what my husband and I looked like. From one day to another, I was thrown into healthcare under probable death, from believing I should go to work the next day and had a full schedule ahead the weeks to come. I was remitted to Sahlgrenska University Hospital in Gothenburg, and I was told that my heart was, well, about 30%, and it was decreasing, and that I needed a heart transplant as soon as possible. An examination of my whole body started to see if I was healthy enough to receive a new heart, and to wait 1.5 weeks to see the results was really, really painful. You know, when you wish for something for your birthday or for Christmas, remember when you were a child and you just wanted to have something really, really bad? That was the feeling. I want to be put up on the waiting list, please. I was 42 years old. I never smoked. I was drinking only at dinner parties, and I mean, quite small, not so very big, and well, I could not walk anymore. The day after I came into the hospital, I needed this rollator, and it was really painful also to not be able to take care of my children. 2 days after the result was delivered, I was accepted to the waiting list. And we had a specialist nurse called in my family for a talk about my situation. She was speaking especially to my sons and said, we don't know or if a heart will come. So, I mean, maybe we need to send your mother home in the meantime. And I still remember, especially my youngest son's face, when he really exclaimed, what will we do then? What if she dies at home? It was hard for me to leave, to see them leave in the evening, and it was, of course, hard for them to leave. But just like a Christmas wonder, a nurse came into my room in the middle of the night and told me, Pernilla, there might be a heart out there that might fit you. So we need to get you ready. I called home, and said to my family, "Don't worry about me. Go to sleep again. I will let you know what happens." Of course, they could not go to sleep. They were driving immediately the 7 miles to Gothenburg, and I saw them just before I went into the operating room. I woke up, and I had a new heart and a new life. You might wonder what's the reason then? The reason why my heart condition was discovered was a sudden heart failure, probably because of the earlier influenza that it was exposed. But the main reason, the doctors told me later on, was that I got a chemo treatment 15 years earlier for lymphoma. And one of many late side effects can affect your heart, something I have never heard of that time. And also, I could say as a side effect from the transplant later on, I had breast cancer. That's another story. My message to you is because of this experience, please learn more about symptoms, but also about side effects, the symptoms of side effects, to prevent other events to come, and take them also just as seriously. Not every story ends with "they lived happily ever after." Thank you for listening.
Stay here. Thank you. Thank you very much, Pernille Gunther, for sharing that very, very moving story and a clear warning to all of us. I would now like to welcome the rest of our panel to the stage. I will introduce you one by one and ask you to join me as I do so. And I start with Dr. Fatima Cardozo. She is director of the breast unit of the Champalimod Center in Lisbon. She's an oncologist and an internal medicine specialist and founder and president of the Advanced Breast Cancer Global Alliance. She's deeply involved in shaping global cancer policy worldwide. Thank you so much for joining us. And it's a pleasure to introduce Dr. Markus Koch. He is the European and heading the European and cardiology, oncology business of Daiichi Sankyo, a European and Canada oncology business. He's also an expert in internal medicine and has practiced at the University Hospital Münster. Welcome. Great to have you on the panel. Dr. Rhonda Seeley-Thomas is Assistant Director of the Pan-American Health Organization, PAHO, at the Regional Office for the Americas of the World Health Organization. And at PAHO, she has been instrumental in shaping the organization's health agenda for the Americas, as well as for non-communicable diseases in the Caribbean. Welcome to you. And we're very happy to have with us Marcia Zambon. She's Executive Director of Europa Donna, the European Breast Cancer Coalition, and responsible for all of its advocacy initiatives, as well as its involvement in research projects and cooperation with other European organizations. Thank you so much for joining. So I'd like to start out with a reminder of the gravity of the challenges that we've been talking about, and particularly how you're seeing this inequity in your own work and or in your personal life, and also why it matters. Why do we need to care about this topic? And I'll just go straight down the panel, starting with Fatima, please.
Well, good morning, everyone. Thank you for the invitation to be here and discuss a topic that is also very close to my heart. So I'm a breast cancer specialist, and I usually say that breast cancer is the most gender unequal cancer that exists. So 99% of patients are women, and 1% are men. And therefore, the women's health is at the center of what I do. And all these years, all these decades that I've dedicated to breast cancer, I still see inequalities every single day. And I would like to say that they are becoming less and less, but it's not correct. I'm afraid that the last decade, probably inequalities have increased and not decreased. We speak more about it, and that's good. But I don't think that we, the title, Time to Action, I'm not sure that we have been having the correct actions. So there are several inequalities that affect women disproportionately. So for cancer, which is my area, so I'll speak more about cancer, but for cardiovascular is the same. Early diagnosis is key. Early diagnosis is linked to education, socioeconomic factors. Those are disproportionately affecting women in relation to that. And then I'll pass very quickly to once you have the disease, there are also a number of factors that affect your life that are also disproportionately worse for women. For example, the probability of you losing your job after you have cancer or a heart attack is very high, but it's higher if you are a woman. And another thing that may shock you or not, the probability of getting divorced after a breast cancer is higher than 40%. And believe me, it's not the same if a man has prostate cancer.
Very, very interesting. I saw you nodding quite enthusiastically when Madabe-san said that health policy, public health, is inextricably bound up with women's health, and you've just given us a clear explication of why that is. I will come back to Pernilla at the end of this round, but let me go now to Marcos.
Yeah, thanks, Melinda. I think, look, I can confirm the topic is close to my heart for a couple of reasons. First of all my life I've been surrounded by very strong women, I would say. My mother was the first in her generation in family, going to university, becoming a doctor. That was new at the time. And my wife is a pediatric oncologist. I have two very strong, independent daughters. So I've seen also in my family life a lot of inequities. I've seen the difficulties in education and healthcare. And of course, as a physician and doctor, I've seen that also in cancer care and in medical service. I think the video in the beginning has made it very clear that we need to take a more comprehensive look. We need to look not just at gender-specific diseases, while there is a lot to do and there is inequities, but also at general diseases that are disproportionately affect women in a holistic sense. And look, breast cancer is a classical example for gender-specific diseases, and to name one number, if you allow, like out of the 2.3 million premature deaths every year, there is good research showing that 1.5 million could be averted, prevented, if women had equal access to healthcare, early diagnosis, and state-of-the-art cancer care. That's a concerning number, I would say. Sure. And another interesting point, the video also made clear that increasing women's health is a very strong socioeconomic factor. It's correlated to welfare of a society, to also economically prosperity. If it was not for fairness, for ethical reason, I think there's also strong societal and economic reasons to act now.
Yeah, public health benefits.
Exactly.
Yeah.
Exactly.
Rhonda.
Thank you. I started my career as a medical officer in an emergency room, and I moved to the Ministry of Health, and now I'm the Assistant Director of the Pan American Health Organization, responsible for technical areas. And over the span of my career, I've seen many inequities for women, specifically throughout their reproductive life course. For example, adolescents, they are exposed to adolescent girls, although I know we're focusing on women, but I want to extend it to adolescents. They are not given access to reproductive and sexual health services, so they end up being pregnant. And that affects them and their children for their entire lives. If we move to the women in their 20s, 30s, and 40s, inequities expose them to cancer, specifically cervical cancer and breast cancer and cardiovascular disease. And then when we get to the end of the reproductive lives, in menopause, something that is not spoken about, they are subject to inequities. So in my life, As a physician and as the assistant director of PAHO, I've seen women exposed to these inequities that affect their lives throughout their reproductive life course. And the time to act is now, to reduce some of the inequities so that women can live more productive lives.
Thank you very much, and thank you for reminding us that this starts very young. It's not simply a matter of adult women, but indeed, as you say, girls and adolescents. Finally, Marcia, please.
So thank you for having me. As Europa Donna, we advocate, we are a coalition of 47 countries. 27 are EU and 20 are not, reaching out to the Eastern European country. And as patient advocates speaking out about the needs and the rights of women living beyond a cancer diagnosis, we have seen in 30 years of activities incredible disparities, and still today, even in EU countries, both for access to population-based screening and participation to screening, because that's also part of the educating the women that they have this right. And in many countries, they actually don't participate. And we're wondering why, if they have the service and they don't access it. And of course, screening is a lifesaver because it's, as Fatima said, early detection is key, especially in breast cancer, with all the advancement in research and treatment for breast cancer. And then, of course, at this point, if you survive or you have more possibility of surviving a breast cancer diagnosis, then you go into quality of life issues, side effects, toxicity of the side effects, and everything that, and social support, and right to work, and right to be forgotten. So the list is never ending, and it's very much, at least as Fatima said, we're into a very gender biased sector with breast cancer, but we work with other female cancers as well. And we're definitely into health and women. So,
thank you very much. I want to take a deeper dive in a moment on the causes behind this disparity all of you are describing. But last word in this round to Pernilla. You told us this powerful story of your own experience. What about in your work as a patient advocate and also as a health policy leader? What are the glaring disparities that you see there?
Well, I think it's incredible that we're even sitting here today, 2024, and discussing this matter. I fought when I was 13 years old and started to be engaged in those matters about the inequalities and so on when I was in high school. I was thinking that, okay, when I'm grown up, it should have changed a lot. And I was, when I was elected member of parliament, I was actually responsible for these matters about equality in parliament. So I think it really needs, a restart of thinking or attitudes. To really have equality as an overarching principle for what we're doing. And that means all of us. In everything we do, we need to point the finger on the problems when they occur. Small or big things, wherever we are, we need to say, is this okay? This really beneficial for women? Or, is it equal? I don't think we should reduce men either to something behind us, because equality for me is really to treat people equally. Mm-hmm. So that's really the main thing, to have it as an overarching principle in your head, in your mind, and see what can we do wherever we are, whatever we do.
So let us shine a light on the invisible, often treated as if it's an invisible gender gap. We have seen initiatives put into place in recent years, but there's still a lot of room for improvement.
Medicine is probably not tailored towards this lady, or this one, or to them. Women are disadvantaged in 64% of medical interventions. Women are affected twice as often by adverse drug reactions and drugs are withdrawn from the market 3.5 times more often due to health risks for women. Also, female symptoms are less well known. Therefore, women are diagnosed later than men for 770 diseases. In women, cancer is diagnosed on average 2.5 years later. In the case of metabolic diseases, the gap is a whopping 4.5 years long. Or issues that occur due to menopause, 4 out of 5 women receive no diagnosis at all. And if a woman has a heart attack, the risk of being misdiagnosed is 50% higher because the symptoms differ from the male norm. It's one more reason why cardiovascular diseases are responsible for 35% of deaths among women. Or pain. Men are given more painkillers even though 7 out of 10 people with chronic pain are women. Hospitals also check the degree of pain 10% less often in women, and before they do that, they make them wait half an hour longer. Money is also not on the women's side. For example, healthcare premiums for women are higher in many countries. In others, women stay absent from work because they can't afford menstrual products. Also, most funding goes to high mortality diseases which affect more men, and less is invested into diseases that impair the quality of life, such as depression, diabetes, or rheumatoid arthritis, which affect more women. Should we cut the healthcare pie differently? Or should we make a bigger pie?
Thank you. Thank you very much. Fatima, not long ago you received the European Society for Medical Oncology's award, and at the award ceremony you decried the fact that we seem to be moving backwards when it comes to the gender disparity. What are the most glaring obstacles? What's impeding progress here?
Well, there are a lot of factors for that, and I'm always a little bit critical of us, women, also, because I think for some reason, probably because of the way we are raised, many of us don't feel comfortable shouting that we have rights. And we also don't speak up about our needs most of the time. We are carers, right? We are the ones taking care of our parents when they get older. Marcia and I were talking about that. So we are the ones taking care of the children. And even if we cry out that this should be equal, it is not, and we accept that. And so I think, and also going up in our careers for our leadership roles, I don't think that women support themselves as much as they could. When I compare what men leaders do for other men and what women leaders do for other women, I feel a little bit embarrassed that we should support ourselves and among ourselves much better than we do. On the other side, when we say we want to have a gender balance, we have to, and this is what I said, to a room much bigger than this one, about 10,000 people and a lot of men. But I said that for us to reach the balance, we have to be unbalanced for a couple of decades. Because if we decide now, let's say that today we decide that in every decision we make, like we have discussed, okay, we keep this in mind and we are very fair and we pick from candidates according to merit, equally one woman, one man. The gender imbalance will remain because it is very unbalanced. So for now, what we have to do for a while is for people who have the same merit, we have to choose the women. And I'm sorry for the men of these generations. I know that you will say it's not fair for you, but it hasn't been fair for the last centuries for us. And if we don't do this change, for giving another number, it will take 286 years to end the gender imbalance. So almost 3 more centuries if we keep doing 1-1. And we're not even doing that 1-1 for all the leadership positions. And why I'm speaking about the leadership positions is that if you're not there in the room where decisions are taken, the decisions will continue to be unbalanced in gender-specific issues. So we have seen about money that goes to research, right? So who takes those decisions?
Yeah.
Right? And I'm not even thinking only about research, but if you want to change all these inequalities, it's much more than research, because we have so much. When we look at what we have in cancer, for example, we have achieved a huge amount of advances. The problem is that those advances are reaching maybe 5% of cancer patients around the world. Mm-hmm. So there needs to be investment in other areas to make what exists accessible to everyone.
Thank you very much. And if I pick up on the point about sometimes maybe to achieve inequality, we have to move in a way that recognizes differences and corrects for them. Let's apply that to the question of research and data, Pernilla, because one thing that I think many of us know, one statistic we're familiar with, and we saw it in the film, is that women's heart disease symptoms are very different from those of men, and therefore often not recognized. And talk a little bit about that, if you would. What do we need in the way of data to really begin to correct what seems like rather glaring bias in the data sets?
Well, at first I think to collect data, you need to really have the real-world evidence collected and really make it, how to say, I mean, since we know the differences between men and women in taking care of symptoms or acknowledge symptoms, I think, I mean, life is going on, and to really feel your body and feel that there's something wrong and to recognize your symptoms and go to the doctor and so on. You really need to see that it's important. It's important for me, of course, but it's also important for my family or for the society. So really to have all these data collected, you know, from people who have suffered or from women who have suffered from heart diseases, I think that's tough sometimes because they also, the symptoms are not discovered as early as we like, and also that they have not been thinking of it as serious as they have become. So I've heard so many people when I worked, especially with heart failure, that people said, oh, I went into the hospital and I said I had, you know, a pain in my stomach or a pain in my back or something, and they just, you know, was sent home without a proper diagnosis. So I really think we need to see that to have correct data, it's always depending on what we put into the systems. And this is a challenge still. I think it is what you said, that we don't know everything that we would like to know to really have these correct figures and facts.
And in fact, you have said in several speeches that many of these issues are invisible because we simply don't shine the light on them. Rhonda, I was looking at statistics for the Caribbean region, and there was one example that immediately caught my attention, and it's related to what you talked about in your opening remarks. Antigua and Barbuda have a disproportionately high rate of cervical cancer, and over 80% of women seeking treatment are coming in at advanced stages of the disease, although in fact it's highly preventable or at least recognizable. What's going on there?
Yes, and thanks for that question. It's not only something that's common to Antigua and Barbuda. It's common to many countries in the Caribbean and Latin America. And the reason for that is cervical cancer, although preventable and treatable, access to services for many women is limited, and services are really not available in some of the countries. For example, in the past, when I started my career as a medical officer, the HPV vaccines were not available. In terms of detection, the pap smear was what was used, and women would go to clinics and they would not have test kits available. If they were available and they did get a test, they would have to wait 3 to 4 months for a result. And if after that 3 to 4 months they did get a result that showed that they had a precancerous lesion or a cancerous lesion, treatment was simply not available. When you look at a small island developing state, you may not have radiotherapy services available, you may not have cryotherapy services available, and women may have to access services in another island, in another country, and financial access is not there for them. So I have to say, though, that over the years, and I was a medical officer 30 years ago, so now in Antigua and Barbuda, they have made very, very significant progress in terms of cervical cancer control with the assistance of the Pan American Health Organization. For example, in terms of the HPV vaccine, it's now available in Antigua and Barbuda for adolescent girls and boys, single dose, free of charge in the public health system. In terms of testing, we've moved, and well, not we, but Antigua and Barbuda has moved from pap smears to HPV testing, and the results are available, you know, in a week or more, a week or less, sorry, for women. And additionally, in terms of treatment, with assistance of PAHO and other partners, treatment services are also available. So yes, things were not so good many years ago, but now things are better in Antigua and Barbuda and in many countries in Latin America and the Caribbean because of the Pan American Health Organization.
And I want to come back to exactly that point and what they're doing later on in a round of discussion about solutions and new approaches. But let's stay with the question of screening and early detection, which you also mentioned, Marzia, and it clearly is absolutely critical when it comes to breast cancer. Again, in Europe, there are still big obstacles standing in the way of that. Can you tell us a little bit more about them?
Yes, so we represent 47 different countries, and in a very small area like Europe, maybe like in the United States, it's a whole country. Now we talk about Europe, but in Europe, in our concept of Europe, because we represent the WHO geographical description of Europe, we go from Tajikistan to Serbia, to Cyprus, to Spain, to Sweden, to Denmark. So different cultures, different mentalities, different money and availability and resources and funding, different governments, different organizations, different languages, different health systems, many of which regional. So once you have the national law, then it has to be implemented at a regional level. Now we had our host before mentioned this 10-year plan that was a game changer in women's health for Japan. Well, we just recently had Europe's Beating Cancer Plan, which was actually promoted under the Ursula von der Leyen administration by the health commissioner Stella Kyriakides, who, by the way, I don't want to brag, but she was president of Europa Donna and founding president of Europa Donna Cyprus. So having twice breast cancer patient and advocate for years arise to such a position actually helped put together an incredible plan with incredible funding for cancer with 4 main pillars, including the first one, prevention. Had it been mentioned until before, every research points to the fact that 40% or more cancer cases can be preventable with positive, changeable lifestyle choices. And this is not a stigma, it's not a pointing the finger, but it's a question of awareness. People, citizens, not patients, women need to know that they can help themselves. And that's the first point. Screening. Screening now in the EU is basically a civil right. In 27, Bulgaria is a little bit, but there is an issue with participation. So in Denmark, it's participated up to 85, 90%. And instead, in Cyprus, 12 or 13 women declare to have had a mammogram in the past 2 years. Why is that? Is this a lack of education? It's a lack of understanding, of awareness. And this is where we come in as patient advocates, because our main role is to educate women to help themselves and ask for help.
And again, that's something I want to drill deeper on a little bit later on. And it relates to a last point I'd like to ask Marcus to talk about a little bit, also starting to move toward our discussion of solutions. At last year's World Health Summit, you spoke as part of the Global Governance Project on the topic of health as a political choice. So tell us what political choices are currently not being made or being made essentially to maintain this unequal status quo?
Oh, thank you for the question, but that's a broad topic, I would say. Yeah. I think we have seen that health policies or women-specific health policies often focused around maternal or reproductive medicine, and the NCDs are often deprioritized, which is something that has to change, I think, for all the reasons that have been mentioned. But looking at the political dimension of this and the societal decision, how we deal with inequity, I would like to come back to what Fatima said, because it's a topic far broader than actually health policies, and it needs to be seen in a more holistic way, I think. One obvious factor is the access to resources, so the socioeconomic questions. And there's lots of research that having a lower socioeconomic, like financial status, is an independent, strong risk factor for worse outcomes in not just cancer, in any disease. That's something that we have not addressed and that can't be addressed by health policies alone. If you look at the proportion of unpaid care work, that is clearly, we all know this, we see that around us shouldered by women. 75% of the care work is done by women. So every day, 11 billion of unpaid hours of work are delivered by women. And that is a societal issue. That's not a health policy topic alone. And that has health implications. We know that in crisis, people responsible for the care work suffer much more. They are much more prone to suffer mental health issues. Mental health issues are also significantly underdiagnosed, but more prevalent in women, for instance, for that reason, right? In the last or third factor, there's more also relating to what Fatima said. When it comes to leadership positions, women are also in healthcare institutions far underrepresented. They deliver the majority of the care work. They are the care providers, but when it comes to leadership roles, if you look at the UICC centers, like cancer centers and research institution, out of the, I think we have 184 or so now, 16%, 1/6, are led by women, which is something we need to act on, and probably it needs some corrective action. I totally agree. I think waiting 286 years might, for most of us here, a little bit too long. So yes, there is more to do, and it's in the end, it's a political agenda, Melinda, totally agree.
Interesting that who is making the decisions certainly shapes what decisions are being made. So how can we do better? Our research team identified several best practice examples of initiatives prioritizing both diagnosis and treatment for women. Let's take a look.
There are examples of women's health as a priority. Here are a few. Breast cancer is the most common cancer in women in almost every country in the world, also in Japan and South Korea. Both countries have high breast cancer rates like other rich nations, but mortality is significantly lower here. As early as 1984, Japan developed its first cancer control plan and declared women's health to be the main pillar of a healthy society. Similar in South Korea. The country is now a world leader in cancer screening for women. 42% of women say they have been tested in the last year. And in the last 2 decades, participation in cancer screening has doubled. But these are rich countries. Lesotho is not. The South African kingdom is fighting HIV/AIDS, which affects twice as many women as men. But with international aid, almost half of all Sotho women are tested for sexually transmitted diseases, in contrast to only 10% of women worldwide, making Lesotho number 1 in the world. Or Costa Rica, a success story in cardiovascular disease, the most fatal disease in women worldwide. Costa Rica has one of the highest blood pressure testing rates in the world and the second highest hypertension treatment rate for women. The result, while 1 in 3 women worldwide dies from cardiovascular disease, the comparable figure in Costa Rica is significantly lower. There is one other factor. In Costa Rica, about half of doctors are women, more than the global average. Studies have shown that a woman is more likely to survive a heart attack when her doctor is a woman.
Let's give our film team a big round of applause. So I'd like to ask all of you to talk about what you think we can learn from initiatives like these, what key success factors you saw in that very quick overview, and also whether you think that we are succeeding at sharing best practices across regions. So address any or all aspects of that you care to. Fatima, please.
So maybe the last point is easy to answer. I think we do not share so well as we could. I mean, we are in the era of technology and information. Everything is at the speed of light, known throughout the world. So I think we need to use this new technology also to share good practices around the world and perhaps adapt to different regions. And one point I wanted to make, and if you look carefully to the examples, none of the examples spoke about very expensive treatments, right? And yet they were all very important and had extremely important results as well. So I think this idea that equality in healthcare means a lot more expenses is not necessarily true. So the very high costs of certain treatments, of certain drugs, not just drugs, but let's say drugs because they're easy to maybe easier to criticize. There are other treatments that are also very expensive. But let's say high technology, radiation, high technology surgery, heart transplants, drugs, all of that is very expensive. But all of that is for a small percentage of the population. Okay? The most important issues are not expensive. So they are either focusing on prevention and early diagnosis, so control of hypertension. It's not expensive. Drugs are not expensive at that level. So there's a lot that we can do that it's not expensive if we really focus on what matters. I think what we need is maybe courage from those who take decisions to think outside the box and to be able to take some decisions that maybe are not going to be popular. And I think, at least from my personal experience every day, people who take a lot of decisions in healthcare, they don't think long term. I'll give you an example. Insurance companies, okay? Insurance companies think of 1 year. The time frame for them is 1 year, instead of being a lifetime, right? Why? Because they say that after a year, the client can change company. Okay? Well, if you treat the client well, the client will not change company. But that's why they don't pay, for example, genetic testing. They don't pay preventive surgery. Let's say you are a woman and you have a BRCA gene. The best preventive measure that you can have is after a certain age, certain prophylactic surgeries, both mastectomy, ovariectomy. Most insurance companies don't pay that. That's out of pocket. Why? Because that doesn't reflect in 1 year. It reflects on your lifetime. And they are incapable of thinking, if I prevent this cancer, I save a lot of money, because if there is a cancer and I have to treat it, it's much more expensive. Yeah. And I give this example because I see it every single day, but there's also the same way of thinking from those who take, the policymakers, the politicians, those who take decisions in the individual countries. They think of short term. Politically, usually you think of short term, but for health, you have to think long term. Yeah. And sometimes you have to take decisions that might not be so popular. So instead of investing in the very last, very expensive drug, why don't you invest in infrastructure? Why don't you invest in human resources, on having adequate number of nurses and doctors to take care of patients?
An idiom is flashing through my mind as you speak. An ounce of prevention is worth a pound of cure. That resources dedicated to prevention will go quite far indeed. Pernilla, what struck you about the initiatives that we saw there and or approaches that you think are really meaningful in addressing the gaps we've been talking about?
We need a plan. No, actually, you mentioned that to say something that is not that popular. I have that coming.
Good. Do it.
Because I think sometimes we attend all these kind of, summits, congresses, conferences, a lot of people. I think ESMO had 30,000 participants during 4 days or something like that. And I always wonder, what will happen when you come home? Don't you think you are a stakeholder when you attend a meeting like this? And especially, this is the World Health Summit. What do you do when you come home to your country? Is there any possibility that you can ally with people here already and say that, okay, let's do something when we come home to Portugal, Spain, Ireland, Sweden, wherever we come from in the world? I think sometimes we are discussing, almost the same thing. And I would really like to address the theme of the World Health Summit, because it really affects healthcare, and that's trust. If you don't trust healthcare, you won't go to the screening. You won't go to test yourself for anything. Since I'm working for the European Commission also with the Europe's Beating Cancer Plan and the financing through Horizon programs and projects, I have discovered when I come out to different countries in Europe at least, that when we have the lowest screening rates, for example, people say, okay, why aren't you going to breast cancer screening? If I do and it discovers I do have cancer, then I need to go to the healthcare system and be part of that, and I don't trust them. Mm-hmm. And I think we need to see that healthcare, according to me at least, is a backbone of society. We are born there. We will probably die there. And everything in between, we need to go there sometimes. So we really need to see that we all of us have an impact if we like to have it, if we like to play a role in increasing possibilities for people to go to healthcare. And I also would like to mention another thing in this matter. It's also the economical situation. And not only it's about healthcare, access and all of that. It's also to provide people with a social insurance system that make them really feel comfortable and feel that they can afford to be sick.
Yeah.
That's also something that we need to address when we're talking about this. So I really get engaged here because I think there are so many things we can do, but we will not solve it, unfortunately, in this panel. I wish we could. But we can do something when we go out from this room and from this meeting.
Thank you for that reminder. Let me jump over to Rhonda to talk also about best practice sharing, because you were telling us a little bit about what the Pan American Health Organization has been able to do to come up with a plan. Maybe you can elaborate on that a little bit. And then I also would be curious to what degree, for small island developing states, digital solutions can perhaps help to promote care for people who otherwise might not have access. It's something I hear in other areas, and I'm wondering if it's true in the health area as well.
Thank you. So what the Pan American Health Organization has done for healthcare and for women's health, I go back to the video that you just showed with Costa Rica, where they've had success in hypertension control for women. And one initiative that PAHO does have is the HEARTS initiative that looks at looking at hypertension control in the Americas, where we provide equipment, we provide training, and also what struck me from that video as well, and I want to make a comment on it, is the last slide was that women get better outcomes when they're treated by women, and it tells us that we have to invest in the education of women and girls if we want to have any success in healthcare for women. And then in terms of digital solutions, yes, in small island developing states and in countries of, for example, Latin America, where access is a problem because of geographical access, because we have communities, indigenous communities, that access to a clinic or a physician, a healthcare provider, is probably not as easy for someone living in an urban area. Digital services can help, and the Pan American Health Organization, we have healthcare using a digital highway where we provide telehealth services in remote communities so that healthcare providers can communicate with other healthcare providers in urban areas, but also patients can also communicate with their healthcare providers using digital solutions. And then also finally, in terms of digital solutions, we have in the Pan American Health Organization a revolving fund where we provide pool procurement for medicines, and we do use digital solutions for demand planning and for access and for distribution of vaccines and other essential technologies.
Thanks very much. Let me go now to the topic of policy levers that can really make a difference, and ask both Marcos and Marcia to comment on that. And Marcos, you told us a moment ago that this has to be an all-of-society approach. This isn't simply about women in one particular disease area, but it's actually about public health as a whole and women's place within that. So tell us what levers you consider to be essential and effective, and where you're seeing them applied well.
Yeah, that's a very good question. I think the short answer is, and Pernilla said it, it's all of us actually, right? It's the individual level where it has to start. I think there's good policy initiatives. We saw a couple of really encouraging examples, and there's more that we could share, and sharing is important. In Japan, BRCA testing is part of the national health plan since 4 or 5 years, I think. That's a good start. There is the ELISA initiative in Europe, where a couple of countries partner, share, build a shared initiative to mitigate breast cancer outcomes. But in the end, I think it's really most importantly a mindset shift. It's the individual level. It's, as you said, once we go home after this conference, or after having addressed that topic, we need to have those discussions at home, in our companies, as healthcare providers, as fathers or mothers, and and also as leaders in healthcare and beyond. So it's really a mindset shift in a societal dimension more than a health policy shift alone, I would say. And that's where we all can do more. And that's why the topic of this meeting and discussion here is very smartly chosen, I would say. It's time to act, and it's not really a cost barrier. You said that. The most impactful initiatives that have been discussed here are not vastly expensive. It's actually really the idea of thinking about women and women's health in all their roles, not just as patients or mothers, but as healthcare providers, as family members, as professionals, as leaders, and then building a plan that addresses specifically the existing inequities.
That was so powerful in the first film that we saw, where we really saw women in all of these different roles that they do play. Marcia, let me ask you also to speak to the policy level, if you like, and talk a little bit more about what policies you think can really drive change in the area of breast cancer. But beyond that, I wanted to ask you about some calls that you've made elsewhere for women to receive the highest standard of care, and what exactly that means when we're talking about breast cancer. What are care approaches that can make a difference in bringing down some of the statistics, the negative statistics we've seen?
Well, highest standards are very much connected with specialized care. So what we have been advocating at European level for years, and Fatima founded and runs one of the best examples in Portugal, is breast unit. So a cancer center where the surgeon is a breast surgeon. The radiologist reads breast and mammograms every day. I mean, you have to have a specialization, and it's just simple logic. If you do something once or 150 times, you're much better at it after the 150th time. So that's, let's say, a basic logical solution. We in Europe have a problem with implementation because we have all these fantastic guidelines and recommendations, but unfortunately the EU does not have legislative power in health. So then it's up to the member state to actually take all those recommendations and make the investments and not just throw money in the health system. I just saw that on average in the EU, states the health expenditure percentage in prevention is 5%. And I mean, this is completely disproportionate. But we can do things, we can do collateral things, and we have to, as Fatima says, think out of the box. And we can do so much at a quality of life level, like she spoke about insurance. I would also speak about flexible working hours, the COVID lesson. It was completely forgotten. I mean, if you are a patient or a caregiver, there should be legislation at an international and national level to allow you to do both in an effective way. Since you're doing it anyway, this change in caregiving being 75% on women, this could be recognized by giving it value, by giving it support at a national level. So also flexible hospital hours, you know, like telemedicine or flexible appointments or mobile clinics, especially for lower income. There's a lot to be done just thinking outside of the box. And one last point about that video with a woman is usually better cared for by a woman. We are working, and we have been for some time, on communication skills of doctors, and which are really lacking in many situations where the doctor has a paternalistic, I know better for you approach. And we are so much trying to shift this to shared making decision, because especially for quality of life or for treatment, adjuvant treatment after surgery, the choices that you can make are not only the length of life, but also the quality of life, and that's so personal that I think it should be treasured.
Thank you very much also for that emphasis on how we communicate, because we know that how people receive a diagnosis can actually affect their prognosis after the disease is recognized. So we have time for a couple of audience questions. I had one here in the third row, here the lady in the brown suit. Where do we have the microphone? Can we get it up here, please? Yes, thank you. And just a moment, I'm going to try to balance the room a little bit. We'll take then this one here from you, and then the one in the middle. Keep your questions short, please, and then we can get several into the mix. And do tell us who you are and where you're from.
Thank you very much. I'm Professor Jayadantis from Curtin University in Australia, and also representing Women in Global Health. Wonderful panel. I had a quick question on two issues that were not discussed in women's health, and one of them was family and domestic violence and sexual health. Sexual health was discussed, but the other thing was also mental health. Women bear a significant burden. They're very resilient, but women bear a significant burden of mental health also, as they carry the weight of the communities and families on them. And the other thing was about clinical trials. Women are underrepresented in clinical trials globally.
A broad spectrum. So briefly, to whom would you like to address that question? We won't have time to take the whole panel. So
with the clinical trials, with anyone in the panel, I'm
okay,
happy with
thanks.
that. But with mental health and family and domestic violence, I think I would go either to Rhonda or to Penela.
Thank you very much. We're going to bundle our questions, so let's all keep that one in mind. And here in the second row, here we are, right there. Thank you.
Thank you for the opportunity. I am Dr. Aditya. I am adult vaccination specialist. I am from India. Just a minute, I'll take a question. The thing is that my question is, everything should start from home. I am being a man. My wife is a doctor, and she's an oral radiologist. Now in my home, to take care of kid, she has quit the job. I have seen this. This we have not seen in the things. My one request is, whichever hospital we are working, there should be a specialty, or there should be an allowance for women to take care of their children. Like they should have a crutch or anything, which if implemented, it would be very nice. I'm coming from an Asian person.
Yeah.
It's very a basic thing, but it is missing in Asian population, because of which the talented and sophisticated surgeon like my wife is sitting at home to take care of 3-month kid.
Yeah. Thank you. I see lots of heads nodding behind you, so we will come to some comments on that a bit later on. So in the middle, I have here a question. Yes, please.
Thank you. My name is Aziz. I represent Green Star from Pakistan. The center stage of all the problems in my country, for example, we have 10 million pregnancies every year, 4 million are unwanted, and 2.8 million abortions. 1,400 women die every year because they did not have the choice to space their pregnancies. Don't we think that family planning should be the center stage? She has the right to choose the timing of her first pregnancy, spacing between the pregnancy, and her view. Because Pakistan, for example, doesn't need anybody to destroy it. The tsunami of population is going to try, and the same is true for the entire world.
Thank you. Thank you very much. I'll take one more right here. Right here, there, where you are. No, okay, sure. Yeah.
Thank you very much, excellent panel. My name is Mary Monica Sando from Dar es Salaam, Tanzania. I'm a medical doctor, but I also am the president-elect for the Medical Women Association of Tanzania. One of our key function has been to really build into creating awareness for women to understand and to take up responsibility for early detection of breast cancer. I would like to learn from the panel on how we can connect at a global level where some of these best practices can truly be resourceful and useful for some of associations like the one that we are trying to run, to be able to advance ourselves, even within those very limited resources. Thank you.
And let me suggest that you also connect after our panel is done individually with some on the panel, because we are going to have, I'm sorry, I'm going to have to cut off the questions there and get some answers. We've had an amazing spectrum here of topics. Clearly, we can't address each one in detail. I'm going to ask each of you to speak to whichever points you consider crucial. And I'll just give a really quick reminder. So we've talked about bias in tests in clinical trials. We've talked about sexual and mental health and sexual rights. We've talked about beginning at home with caregiving, and we've talked also now about the breast cancer outreach and networking. So, Fatima, any or all?
So I'll start with clinical trials. I think there are a lot of barriers to access to clinical trials. And most of those barriers, we could get rid of them because the clinical trials have become so bureaucratic, so much administrative work, and so heavy on the patients. So for example, I work in a specialized breast unit. The first barrier is where you live. If you live very far away from the place where you've been taken care of, immediately we don't consider for trials because the trials make you go to the hospital so often and you're just not able to do that. It's too expensive, you lose your work, so it's just not possible. So I think altogether, all of us together that are involved in drug development and clinical trials, we have to plead for a change on that, making trials less burdensome for the teams and especially for the patients. And then we can have more people involved. One point about the clinical trials and drug development. I don't know if most of you know that any drug for any type of disease is tested first in healthy volunteers. But if you look at the studies, they are usually white, male, healthy volunteers. Mm-hmm. Okay, so the doses we use then in a clinical practice are good for an average white male, but not for female and not for all the minorities. Mm-hmm. Okay, so we have then to continue to study, and that's why we have so much more toxicity for female, because the doses are not adequate. So already there, it's a low-hanging fruit, let's say, that we could change the way we do drug development.
Thank you. Just on the clinical trials, one-word answer, if you would. Digital inclusion, digital participation, is that a possible solution to bring more women in? Yes or no?
Maybe.
Okay.
Depends on the trial.
I can probably add just one sentence because clinical trials obviously is something that, Fatima, we need to partner, and I think we do partner as drug developing companies with the academic centers. Totally agree. Access to clinical trials, we are not yet where we want to be. There is more support for patients needed. We just last week had a discussion with patient advocates exactly around this topic. So I can say we are committed to be part of the change. We see the issue and we want to do more. Mm-hmm. And again, it's a topic that we need to, because it's broader. It's not just women's health and gender inequity, but we need to build a plan that specifically addresses the needs of women who are even less represented there.
Rhonda.
Yeah, I think the question from the participant from Australia was specifically for me. I think you asked on mental health and domestic violence. Certainly in mental health, women and men are affected, but we know that women are affected more. And we know that women alone can suffer from, well, not alone, but more than likely to suffer from postpartum depression. And it's something that's undiagnosed. It's treated sometimes casually in some societies, and we need to pay more attention to mental health in women, and specifically postpartum depression in women. At the Pan American Health Organization, we are focusing on mental health, and we have policies and programs to assist countries in dealing with mental health issues specifically for women. Domestic violence, again, both men and women are affected, but women disproportionately. And I think we need to empower women more. We need to have our healthcare providers and law enforcement persons recognize and appreciate that domestic violence does exist, and that they should provide more support to women when they access care and when they access protective services.
Recognizing reproductive rights was also a question that a Pakistani questioner posed. Do you want to speak to that very briefly?
Certainly, reproductive rights are very important. You spoke about women having access, and you spoke about abortions as well. I think it's something that women should have access to, and again, healthcare providers. And a lot of people think that there could be spontaneous abortions, and women need to have proper access to services when that does happen. And we need to provide services where women can space their pregnancies, where they have an active role to play in their own bodies and their own lives, so that they can have productive lives for themselves and their children and their families and societies as a whole.
Thank you. Marcia.
Yeah. Building up on that, I was having a conversation regarding changes, the silent revolution that was two specific factors. One is the birth control pill, and the other is social acceptance of the concept of divorce. These were two very important steps that nobody realized, but in our decades of generations, since 1970s, and at least in the Western world, have completely changed the role, the potential role, and the self-determination of the role of a woman in society. So I think that's a very good point.
That's very interesting. Thank you. I will give the last word to Pernilla, and Fatima. Okay, pre-last word, short, if you would.
Very quickly, it's just to highlight that this is one of the issues where we're going back. Just look at the US and what's happening with abortion.
Yeah, true. And Pernilla, finally, you mentioned in your first story to us your own dual role at the time that you had your heart event, namely that you were in the middle of life with young children. We had that very powerful contribution saying, how can we do better at recognizing caregivers' multiple roles that they are playing and how that affects their ability to deliver in both places?
I think it's so important that we see the need of equality. I come from the most, used to say that Sweden have the best equality in the world, and I think we do have the social insurance rights to stay home, both mom and dads, at totally exact conditions. So we can choose whether the mom or dad is staying at home from day 10. Actually, the father needs to be home also for 10 days in the beginning. He's not forced to, but I think he should wish to be home for the first 10 days at least. So I think we do have the legislation. We do have all the things set for having a good and equal society. But we are not satisfied in Sweden. I don't think we should be that in anywhere in the world, because we have still so much to do. Because it's what I said before, it's a mindset, how we think about these things. In Sweden nowadays, we have a saying that's called parenthood. The fathers who stay at home with their children, they are called latte fathers, because they go out at cafes, and meet each other. But I will also say a few words about this topic about domestic violence, because I do think it's really, really sets the points of equality and human rights, and especially so far women's rights at this really, really main point of what we're discussing here. The healthcare needs to take responsibility. And in Sweden, actually, the GPs have the obligation to acknowledge if a woman have been put out for some kind of violence, and they need to report it to the police. So we can also provide healthcare providers with the right tools.
Thank you very much. I think all of you have done a lot to tell us about the tools that we can use to turn commitment into action. Let's please give our panel a very warm round of applause. It's been a very insightful and also inspiring discussion, and we're very, very grateful to you for being with us. And I think all of us are very grateful to our hosts at Daiichi Sankyo for making this discussion possible. Thank you very much to Dr. Manabe-san and the whole team for your support. I wish everyone a great day, lots of interesting discussions, hopefully. I wish you good health and hope that our paths cross again. Goodbye.